Okay, our next presenter this morning is Karen Daley. She is a current board member of the International Safety Center, a past ANA president, one of modern healthcare's 100 most influential people in healthcare, and included in the Modern Healthcare Top 25 Women in Healthcare. We're so glad to have you join us today. Would you please?
Sure.
So one of my goals is to not knock this water over. Thank you, Tamara. The presentation that I'm giving is on behalf of the International Safety Center. Normally, I know you'd have Amber Mitchell here. Amber had a scheduling conflict, so I stepped in as a board member, besides the fact that I have a sister in Charleston and I'm looking forward to seeing for a few days. What I'd like to do over the next hour is really identify trends, impact, and potential preventive strategies around sharps injuries and also blood and body fluid exposures. I have to say that, I appreciated being able to see Wendy's presentation prior to this, as you all have PHT data that's separated out. This data comes from the entire data set at International at EpiNet. So what you're going to see will provide just a sense of where things are going in year-to-year trends, et cetera. And we'll have some takeaways that I'll share with you at the end of this. Right. It doesn't want to move.
Oh.
Let me try another.
Let's see.
Oh, go that one.
Okay.
So for those of you who may or may not be familiar with EpiNet, just a reminder, it's a surveillance system database that's disseminated by the International Safety Center. It was established in 1992, so it's been collecting data. It's a proprietary data set. So you have institutions from across, not just the United States, but also across the world who use the database as a way to collect their data and generate reports so that they can identify trends and hopefully improve safety within their facilities. The data I'm going to present today, some of it's rate data and some of it's raw data, as Wendy just presented for PHT. So, what's unique about the International Safety Center EpiNet database is that, and you all benefit from it. Amber collects, and she's been a long-standing proponent of collecting data on blood and body fluid exposure, separate and apart from sharps injuries. It's really important data. As you'll see, hopefully by the end of the presentation, it's data that I think we can do a lot to improve safety for your workers around, and the current data raises a lot of concern, certainly for me, and I know for Amber as well. So this data set, for those of you who have facilities that do use it, it's not software, it's actually, these are just drop-down menus that allow collection and then analysis of the data, and reports are generated on a public website that's available anytime through the International Safety Center website. Again, the rates are based on average daily census. That's the denominator that allows us to calculate rates. In the 2020 data set, there's 41 health systems or facilities that are included that have reported. And again, the reports are provided on an annual basis. And this is what you'll see if you go on the website, is based on year. And you'll see 2 columns of data under each field. One is the actual N, the raw data, and then a percentage of the whole. So I'm going to go over some trends that we've seen over the past year based on the EpiNet surveillance. This slide provides a breakdown according to not only the total number, and from the year, I'm going to be challenged to see the year on some of these. I think it's 16 starts, and this one goes up to 19. 20. It does go up to 20. my contacts need to be adjusted.
It's small.
But you can see there's an overall downward trend in terms of the total number of reports. Teaching hospitals on the slider in red. Green is the non-teaching hospitals, and pretty consistently, teaching hospitals have a tendency to have more reports of sharp injuries than the non-teaching hospitals. Whether that represents an actual accurate count of the injuries is a question, but based on reports, this is what we're seeing. As we look at the breakdown according to occupation, and the way EpiNet breaks it out, you'll see there's two MD groups on the right side of this pie chart that are separate. And then there's surgical attendings. We're going to talk about surgical attendings separate from the MDs. These are licensed MDs, not the med students. This is a year where we're seeing almost a close, when we break it out that way, a close percentage of reports coming both from licensed physicians and nurses. So historically, we've seen a lot of years where the nurses really outnumbered physicians in terms of the numbers of report. This year, we're starting to see, and I think COVID has raised some issues for people. I think concerns are growing in terms of safety and the need to make sure that there's no issues. The surgical attendings, again, are in this pie chart in a separate grouping because the ORs are an area of great concern. They continue to be an area of great concern, and with their own unique challenges in terms of both the paucity of safety design around sharps that are used, the amount of blood in the fields, confined space. There's lots of factors that contribute to concerns that I think underlie OR injuries, not the least of which is the culture, which, the surgeons to a large extent, this is their fiefdom, the OR. So it's a difficult place to shift culture and to change attitudes around safety. But again, the fact that the physicians, the level of reporting from physicians and nurses are close to one another now, I think tells you something about an increased level of concern. This is a pie chart that actually breaks out the actual devices. And I apologize, I don't know how sutures got up in that upper right-hand corner and the disposable. They should be flipped, because actually, not only in 2020, but for the past 4 years, we've seen the suture needles outnumber. They outpace the number of injuries reported based on the type of device over disposable syringes, and that's again a great concern because we know we have some options within the OR. Particularly, some of these are procedure rooms, some of them are patient rooms, but for the most part, these are OR injuries that involve sutures. And we know we have blunted suture needles with a lot of resistance from the physicians around using them to close fascia. So that's an area of concern that continues to be evident in the data. There's some side text boxes here. Among the disposable syringe numbers, and it's about 17%, about a quarter of them are from insulin syringes, and that really is about, I think, a continuing growth in the number of diabetics we're seeing in insulin-dependent diabetics in this country. Sorry. Dang, blind.
You're fine.
Oh, this is patient rooms. So about 23% in patient rooms, and again, the 43.7% in the OR. And this to me, of all the data relative to the sharps injuries, this data is of great concern. Only about 36% of the people reporting sharps-related injuries were using a safety device. And of those reporters, about 67% didn't activate the device. And we can talk about that more, what that potentially could mean. That to me is a real concern. We have safety devices, people aren't activating the mechanisms. I think it could be a combination, can't isolate them based on the data we have at EpiNet, but we know that, there's issues like, was training provided on the device? Is the device outdated? Is there a perception that device safety mechanism isn't a good one? So it's more expedient for the worker to avoid activating it. Any of those concerns should lead to a bit of adaptation or adjustment in terms of how you approach this particular piece of information. And this is just a breakdown between 2019 and 2020. Again, the same information I just shared. You can see the difference in terms of the physician reports. The percentages significantly increased. Again, that's safety design. It went from 52% in 2019, the number of people reporting using or being injured with a device that had a safety design, to only 37%. So that's a major concern for, I think, anyone with employees who use sharps or in direct care. You need to ask yourself, are we using the device that really the workers are willing to use? Are we training them appropriately on it? Are there other factors in the environment that are kind of contributing to this phenomenon? It really demonstrates, I think, some potential for preventive kind of adaptation. The other thing that you can see on this slide is that about 32% of the injuries that were reported with sharps occurred during activation. That again says either it's a technique where there's a design where someone got their finger in front of a sharp as it was being activated, or the design itself was poor. So this kind of data really should kind of signal the need to really take a more close look at what's going on. This is just an example. I wanted to just include an example of what the data looks like when you go on the website. Again, you can see the two columns of data. The raw data is presented in N. And overall, in 2020, there are 1,331 injuries that are in this database for that period. And then the percentage of the whole. Now, again, unique to EpiNet, because I come from Massachusetts where we have a surveillance system that collects or mandates reporting from all the hospitals and any facilities that are under the license, the DPH license. In Massachusetts, the Department of Public Health licenses facilities, hospitals, and any standing surgical centers, etc., are also required under the law to report all the injuries. We don't collect this in Massachusetts. I wish we did. And you're going to see some data. I think that's pretty startling. But with a potential, I think, to reduce the incidence of exposures based on the data we're seeing. So here, overall, this is the 2016 to 19 exposures. Teaching, again, is in red. Blue is the total. And then these are rates, and then the non-teaching in green. You can see that not too different, 19 and 18. Little decrease. Here are the patient areas that the exposures were reportedly occurred. I think that again, the OR and PACU, and if you think about the OR and PACU, of all the places that really you would expect people to be at barrier protection from head to toe, and to still see splash exposures, that's a concern. Might be a circulating nurse, I don't know, but again, it would need to take a closer look at that. And then the patient rooms is the dominant area where you see these kinds of exposures occur. This is, I think, this and the next slide are the two of the major takeaways of this data from 2020. And if you think 2020 was the year of COVID, so everyone was wearing shields, hopefully total face covering, but not based on this data. 81% of the reported exposures were to the face. That included the eyes, the nose, and the mouth. About 33% occurred in the eyes. And that raises for me some significant concerns. I think it's discretionary in terms of the individual provider, how they gown, glove, etc. I think we need to really rethink that and consider the potential risk. You know, mucous membrane exposures were a potential opportunity for COVID infection to be transmitted. So the fact that we have so many, and this is the slide that goes with it. The blue lines on this rate graph are the actual eyes only rates. And then the red is the number of people with eye covering, eye protection. So you can see there's been a slight increase from 19 to 20, but not what you would expect commensurate with what happened in our healthcare system over the past year. So I think, you know, I think this isn't just PhD, but this is everywhere. We need to rethink how we're teaching and overseeing care of the patients in terms of protecting, making sure that workers take advantage of all the barrier protection as they're caring for patients. And again, same thing on the eye protection worn. You can see there's a little bit of an increase, but a huge gap in terms of the exposure and the face protection that was worn. And again, eye protection being the key takeaway here. This is another issue that's always been of great concern, and the fact that there are downstream injuries with these sharps injuries is unacceptable. We have healthcare workers who are on the team, housekeeping, central, any place where they're processing sterile equipment, et cetera, and it's not actually, the kits aren't actually, or they're sent down, the contaminated sharps aren't removed if they're not being re-sterilized. But the fact is, this is a really vulnerable population. The fact that we have almost 21% of injuries reported as the non-direct user. These are people who may or may not understand that they're not responsible for something like this occurring and may not report. I would suspect this is a real underreported number because a lot of people who would work in these roles might not have the information or the confidence that they can report and keep their jobs, that they will not be blamed for what occurred. So I don't think this is something that we also want to make sure that we pay attention to it, because, you know, we need everyone in the healthcare system at this point. We're losing, as it is, an awful lot of people, and we need to value the contribution that every member of the team makes and not put other people at risk unnecessarily. So these are some of the top line data pieces. Again, nurses sustained 36%, but physicians were right on their heels if you leave out the surgical attendings. The downstream worker injuries that were reported, 21%. The skin injection and the fact that insulin needles, even though it's small gauge, it's still a reportable exposure. Obviously, it's happening at a higher frequency, at about a quarter of all the disposable syringe related injuries. And then again, 4 years in a row, suture injuries. So there is the potential, again, with the suture injuries to reduce the incidence with blunt suture needles for fascia closure within the OR. More top line data. This is a significant concern to Amber and everyone that's at the safety center. The 55% of injured employees indicated they weren't using a safety device. That meant even in the place where it was appropriate to use one, that they were still had conventional devices available. We're talking about hypodermic needles in some instances. And when you compare it to the numbers in 2019, unacceptable. And about 43% of these were sutures. So surgical teams, again, are high-risk population between scalpels, sutures, etc. And the fact that we have some potential to reduce those injuries and change the culture a bit really needs attention. Half of the splashes and splatters of blood and fluid, body fluids, are to nurses. And I think this is a typo. This was it's about 81% of all blood and body fluid exposures are to the face and head, and only 31% of those who reported the exposures were wearing any kind of protective PPE over their face. So the impact of these injuries, what we know, and again, I apologize if this is old news for all of you, but my injury to date, and I had a needle stick injury when I was working. I worked in a Boston teaching hospital. It's a level 1 trauma center, and I about 26 years, and 22 of those, the last 22, are in the emergency department. And I left clinical practice because of a needle stick injury that infected me with HIV and hepatitis C. It was a preventable injury. I can tell you without one hospitalization that my care has cost over $1 million, including the drugs I have to take on a daily basis and the care that I require in between my visits to my primary. So there are direct and indirect costs associated with these sharps injuries. The direct are the PEP, anything related to initial evaluation and follow-up. And then the indirect, you potentially have people out of work because they're sick from the drugs, so you need to replace that worker because they may make a decision to actually leave clinical practice. What we don't know a lot about, and we know that the number of reported injuries, actually, if you look at the CDC website, it's something that is of concern to me, that we don't have a national surveillance system anymore out of the CDC or NIOSH. We used to have the NASH system, and they eliminated it after the Congress passed the legislation. They extrapolated out that within 5 years we almost eliminate preventable injuries. Unfortunately, that hasn't occurred for a lot of reasons. But the reality is, infections are a rare event. And if that's how you're going to measure the impact, we miss a lot of what people experience as a result of these injuries. It certainly has the potential for creating a huge human toll in terms of how people, whether it's waiting for your test result. I did a dissertation, I was at Boston College for my PhD, and my dissertation was on the lived experience of percutaneous injuries. And I can tell you that every nurse I interviewed, and none of them seroconverted, all of them talked about what the experience kind of put them through. Not just the emotional toll from the standpoint of right after the injury occurred, but the thoughts they had around their families and leaving their careers. And, some had health effects from things like MRSA that we don't normally think about when we think about it with sharps injuries. So the stress, the turnover, I can tell you it was almost a universal experience when people had sharps injuries. It also was tied to whether they had a positive experience in the follow-up, the post-exposure visit. A lot of them no longer trusted their reporter. So it does affect morale overall if they stay in your units. Most of the data we do have is qualitative. But again, the suggestion is there's a significant psychological burden with these bloodborne pathogen exposures through sharps injuries. The rest of the time I have, I just want to speak about prevention. And before I talk about mitigating strategies, I just want to talk about some of the factors that contributed to preventable sharps injuries and exposures to bloodborne pathogens. Lack of compliance with standard precautions. And again, I do think we need to rethink how we orient workers to the whole protocol around protecting themselves when it comes to barrier precautions, particularly as we're talking about eye protection. I don't think it should be a discretionary thing when they're working around fluids that potentially carry blood. So we need to rethink that within our facilities across the country. I think in spite of that, there's still even though these tools like safety engineered devices are available, there's a failure sometimes to utilize them and to utilize the PPE where it's appropriate. So somehow we need to get a handle on that. This third bullet is one for me that I think we have a ways to go in terms of making sure that we have the most effective devices within your particular units. And under the law, there is a requirement that on an annual basis, people review their data, and you do a root cause analysis in terms of what you're seeing. And you take a look at the devices currently in use within your facilities and make sure there's nothing more effective on the market. And if there is, you need to trial that and use the direct caregivers to be the people that will trial the devices. Now, our thinking in the legislation, I was involved with getting the legislation passed in Congress. The thinking behind involving the direct users of these devices in this evaluation and selection of the devices is that there would be more buy-in in terms of making sure that they were used appropriately in the care of patients. I think, and I'm not talking specifically about your region or your facilities, but I think there's been a sense with all the demands in healthcare that once you meet the letter of the law, you're okay. So if you have safety devices within your facility and the likelihood is OSHA isn't going to come around maybe once every 75 years, come knocking on your door, that you can take that risk and the fines aren't that great. There's a lot of factors, I think, that go into decision making, but we've seen a lot of advances in terms of safety engineered devices. Looking at the potential human toll, but also the financial cost of these injuries when one occurs. To look at my experience of $1 million without ever having been hospitalized. It really does, I think, provide an important reminder that we need to look at what the tools are that we're giving the workers and that they're the most effective, not the most expensive, the most effective from the standpoint of the workers. Absent or inadequate training on the use of devices, and I know this is challenging because we have a lot of this constant change and flux in terms of what the equipment that people need to use in the care of patient in the care settings, but training is important. The other piece of that, though, if you have a safety device that you're introducing into your unit and it requires a lot of training, it's not a good safety device. I think that's an important addendum to the whole issue around training. It shouldn't be intuitive. There should be some mention of the fact that a new device is being used so that people take advantage of the design and the mechanism for protecting themselves. On the other hand, if it requires 2-day in-service, it's not a good device. So just something to keep in mind. Failure to activate the safety injury prevention mechanism and observe safe practices, that's a big concern as well. Improper disposal of contaminated sharps. I can tell you in the emergency department at the Boston Teaching Hospital I worked at, when we were in the trauma room with a patient and it gets really crowded, similar to the OR, and you're putting in lines and you're intubating and you're doing a lot of things all at once, there was a habit that we all got into, myself included, of sticking the angiocath needle, once the IV was in the side of the stretcher, into the foam stretcher. And then those are the kinds of things where you can get housekeeping that end up getting stuck with contaminated sharps. So improper disposal, And again, lack of attention to the containers themselves. They should be eye level. If they're getting overfilled and not getting empty, that was how my injury occurred, actually. I couldn't see. And I went to put my needle in the box, and I was holding the venipuncture site. I went to put it in, and I got stuck because there were protruding needles on a box that hadn't been emptied. So attention to the disposal containers is important. Other mitigating factors potentially for reducing sharps injuries. I think we need to think more and spend more time kind of critically evaluating how often we need to use a needle to administer medication. I think the physicians have a tendency just to write an IM or whatever on a medication that could be potentially effective in an oral form. It's just something to think about. Also, that we correct the size of the needle and the gauge that we're using because we know that the risk goes down as you reduce the gauge on the needle if it's hollow bore. So that's an important consideration. Again, safety device activation, it's worth a conversation with your staff. If you find high levels of injuries that involved devices that weren't activated, then it's probably time for a conversation with your staff or survey to see what the potential issue could be, why they're not activating. And it could be the device, it could be time, it could be a lot of different factors. But it's an important thing, I think, to delve into in order to reduce that potential risk factor. Again, I've mentioned the evaluation for more effective devices on the market is important, and we keep an eye on what's happening. And there are a lot more innovative kind of products that are available. We've moved far away from the manual kind of, the sleeve, the sheath, the manual hinged arm. There are better devices there that are easy to activate that we need to be making available to the direct care workers. Recapping and eliminating recapping and needle transfers from syringe to blood tube. That was in the 90s when the Sentinel, I think the warning came up with CDC or OSHA. And that's made a big difference, actually. So that's been a really effective strategy, but I have to remind people every once in a while that's something that you're seeing when you units. And again, making sure proper disposal of contaminated sharps is occurring. Training. Do a walkthrough in your units and make sure people are using appropriate PPE for patients, particularly in the emergency department, patient rooms where we know we get a lot of splash exposures. And then, we don't talk about this much, and you won't find it's rarely mentioned on the OSHA website, but situational staffing for patients that are confused or difficult, or just to be, the direct users of sharps need to be present where they are when they're using sharps. They need to, if they need some support in terms of making sure the patient's not moving or pulling or whatever, just to do that quick assessment before you go near a patient with a sharp. It's one of those factors that impacts the incidence. And then obviously observing best practices for injury prevention and post-exposure care. The last few slides, I just thought I'd end with a few quotes. This is from Janine Jagger, and those of you who've been doing this work around safety, including sharps injury prevention, would know Janine preceded Amber Mitchell at the International Safety Center when it was at UVA. Janine, she was the one to establish the Safety Center in the early 90s. This is a quote from her: "Every healthcare worker should be armed with the right knowledge, because knowledge is the affordable resource. If they have the knowledge, they can use their knowledge and creativity to find solutions within their own environment." And this holds true for whether it's United States or a developing country, that we need to make sure that people are informed so that they can make the right decisions around their health and safety. This is Dr. Dotz, who's Executive Director at Women in Global Health. I hope COVID-19 will lead to a new recognition for the work and risk taken by healthcare workers, the majority of whom are women, and decent work conditions they deserve. You know, it's easy to forget how good we have it in healthcare here. If you travel around the world and see how little people have, and especially in developing countries, and the potential it has to really decimate a workforce. I had the opportunity to go to Taiwan. It was in the early 2000s, and to listen to someone from the UN who had stopped in sub-Saharan Africa every year on his way to doing his work at the UN. And he talked about a period of 6 years that had gone by since he visited the workers in this particular country in Africa. And he said in the 6 years after the AIDS epidemic broke, he saw a 40% reduction in the number of healthcare workers that were available. The other part of it is some people are emigrating out of those countries, and we have to be careful about how we do that work too. We have shortages here. It doesn't do any good not to pay attention to the needs within other countries as well. But Dr. Judd talks about the fact that this is largely healthcare work, and particularly the level of direct care is largely women's work. What that does to a society when you potentially not only put people at risk, but have them infected with a disease like HIV or hepatitis C. And then this is something that I carry with me in terms of my own belief. I have a real problem with the fact that we still silo worker safety and patient safety. Some of that's tied to reimbursement, but the reality is when workers are safer, patients are safe. And until we get that in our mindset and really create systems and resources that will improve safety and health for both, I think we're going to struggle in terms of preventing significant injury and preventable injury. So that is presentation.
Right.